So, Dr. Horowitz, please give a lecture. The title is Gut Peptides.
Thank you very much. It's a pleasure to be here, and I'd like to thank the organising committee. We were talking and I explained that I've had a clear wish never to move more than 4 kilometres from my place of birth. Now, gut peptides is too extensive, and I'm going to talk about the incretin hormones for obvious reasons. There's been extensive research activity relating to gut peptides, you could call it gastrointestinal endocrinology, for more than 100 years. And this research has clearly been highly productive, but there's a long-standing criticism about the relative absence of clinical translation of these observations. But that criticism is certainly no longer valid. For example, I could have talked about ghrelin. So ghrelin, a hormone discovered in the stomach which affects gut motility. Who would have thought? And as Professor Kojima, discoverer of ghrelin, said, the only flaw with ghrelin I know is the difficulty of pronouncing it correctly, at least for us here in Japan. Because, of course, we're seeing the widespread development of ghrelin agonists and antagonists for conditions as diverse as malnutrition to gastroparesis. Now, I've elected to talk about the incretin hormones because research in this area has led to a redefinition of concepts of both the pathophysiology, and it has clearly modified the management of diabetes. So we've had the clear translation in this case. So what I'm going to do in the next 40 minutes or so is tell you a story of the development of the incretin concept, which comes from science, research, experiments, to translation and compounds that we're now using. And perhaps that translation has occurred later than should have. So I'm trying to cover a lot. This is a cartoon of the Australian Ironman Championship, and I believe this person has a striking resemblance to my colleague Mark Cooper, who's giving a plenary lecture later in the symposium. So if we start with Michael Nauk's paper published many years ago in the Journal of Clinical Endocrinology and Metabolism, 1986. This is the incretin effect, and it shows that when you match blood glucose levels from intravenous and oral glucose loads, there's a substantially greater C-peptide or insulin response to the oral when compared to the intravenous glucose. It's not a subtle difference, and how did it take till 1986 or so to get there? So the history of the incretin concept, and I think this is an interesting story, is really 4 phases. The concept of so-called chemical control of the functions of the body, early 1900s. 1923 to 40, the search for an intestinal chemical excitant of the pancreatic islets in secretin extracts. Then 1940 to 63, condemnation of the incretin concept, where there was really no further research for 25 years. Extraordinary concept. And then from 1964, the golden era, where there was proof of the incretin concept and characterisation of the 2 known incretin hormones. And if you look at this story, it's marked by good fortune and luck rather than targeted drug discovery. And Jerome Karl, who was a Nobel laureate, in fact, in chemistry, wrote, some researchers believe that useful products are the result of targeted research, that is, a research specifically designed to produce a desired product. But the examples show that progress is often made in a different way. Like the Princess of Serendip, researchers often find different, sometimes greater riches than the ones they're seeking. And it's definitely true of this. So if we go back to 1902, Bayliss and Starling published their seminal paper in the Journal of Physiology called The Mechanisms of Pancreatic Secretion. and they showed that an extract from the duodenum, when injected intravenously, was able to stimulate pancreatic exocrine secretion. And they called this substance secretin. Now, this is really the birth of gastrointestinal endocrinology, because until that time, particularly under the influence of Pavlov, it was thought that the control of bodily functions were essentially all neural. Now, so this was a critical observation, followed by Starling giving this 4 so-called Cronian lectures related to the chemical correlation of the functions of the body. And he introduced for the first time the term hormone, which is a substance which is released, travels in the bloodstream to influence the function of another organ. Now, soon after that, it was already thought this could have something to do with diabetes. So, in fact, Moore studied the effects of a pancreatic extract in 3 patients with type 1 diabetes with variable results. But he thought this could affect the function of the so-called pancreatic internal function, it was called. And he got variable results. He probably had one of the patients at least with honeymoon diabetes, but it would not be expected to work because he gave the substance orally, and any peptide will be destroyed where Bayliss and Starling gave their extract intravenously. So it's an interesting start. Then in 1921, I think it was, insulin was discovered by Banting and Best. And in 1929, Zuntz and Labar, they were Belgian physiologists, had a seminal paper where they reported in that paper 10 other studies looking at the effect of pancreatic extracts on blood glucose. And these extracts were given sometimes orally, sometimes rectally, sometimes intravenously, sometimes subcutaneously, and the results were variable. But they attributed the inconsistency of the results to variability in the amount of substance that was in the isolate. So they didn't think of the route of administration. And then in 1932, so a long time ago, Labar introduced the term incretin, and he said that this would be a